Hello guys, welcome to podcast 24 of Let's Revise MBBS, and today we are going to talk about postpartum hemorrhage. Okay, so it is hemorrhage after the delivery. So normal blood loss in vaginal delivery should be less than 500 ml, and after C-section it should be less than 1000 ml. In case the blood loss is more than these respective values, 500 ml and 1000 ml, within 24 hours to 12 weeks, then we can classify it as PPH. Okay, but according to ACOG, they have said that no matter whatever the type of delivery, either vaginal delivery or C-section, if the blood loss is more than 1000 ml, then we can straight away classify it as PPH. Okay, now what can be the causes for PPH? We divide it into 4 T's: tone, trauma, tissue and thrombin. The two main causes are tone and trauma. So decreased tone and trauma. Decreased tone is the most common cause. So we have seen that in the third stage of labor there is delivery of placenta and there can be a lot of bleeding. But since the tone of the uterus is high, the middle layer of the myometrium act as a living ligature and they kind of seal the blood vessels. Okay, and they help in stopping the PPH. But if there is decreased tone, it can lead to PPH, and this we saw is the most common cause. The second most common cause is trauma. In case there is trauma to uterus, direct trauma to uterus or to blood vessels or cervix, okay, or perineal tear, all these can cause traumatic PPH. Now let's see about causes of atonic uterus. So first first cause is that if there is over distension of uterus, okay, then there can be, the tone can decrease. Okay, so like in heart we know that if there is stretching within the physiological limit, then the contraction increases. Okay, but if there is excessive dilatation of heart, then it can lead to systolic failure. Right, similarly here, if there is over distension, it can lead to atonic PPH. So what can be the causes for over distension? Polyhydramnios, twin pregnancy, okay, grand multiparity. So all this can be macrosomia, all this can be causes for over distension, and that can lead to atonic PPH. Other causes are if there is prolonged labor or adherent placenta, okay, or if there is fibroid, it can lead to it increases the surface area and it can also lead to PPH. Okay, so these are the causes of atonic PPH. What can be the causes of traumatic PPH? We have seen perineal tear, cervical tear, hematoma or rupture of uterus. So these can be the causes of traumatic PPH. So how do we manage this PPH? Whenever a patient comes with PPH or is in PPH, the first thing to do is resuscitate the patient. Okay, as always, insert 2 large bore IV cannula and start IV fluids. Take her blood group. Okay, arrange for blood. We may need to give the blood. So how do we decide whether we need to give her blood, we need to give her blood transfusion or not? So there is an index which is called shock index, which is heart rate divided by systolic blood pressure. Okay, so normally this shock index should be around 0.5 to 0.7. Okay, we can easily calculate. So heart rate is around 70, systolic blood pressure 120, 130. So the ratio comes in between 0.5 to 0.7. So normal is 0.5 to 0.7. In case there is lot of blood loss, there will be increase in heart rate and decrease in systolic blood pressure. So the ratio will increase. So if the ratio is more than 0.9 to 1.1, then that is an indication that we need to give blood transfusion. Okay, 0.9 to 1.1. Okay, this is the first step. Now second step is to identify whether it is atonic PPH or tonic PPH or traumatic PPH. Okay, atonic PPH or traumatic PPH. Now if it is atonic PPH, when we try to palpate uterus per abdominally, uterus will not be palpable because there is no tone. If it is traumatic, the uterus has tone. So if we try to palpate, the uterus is palpable. So that's how you differentiate whether the PPH is atonic or traumatic. Now let's suppose that the PPH is atonic PPH. So how do we manage it? The next step after identifying that it is atonic PPH is to start uterotonic agents. Okay, so WHO has stated certain guidelines, the order in which we must give the drugs. So it says that first we should give oxytocin, along with it we should do uterine massage and give tranexamic acid. Okay, the dose of oxytocin is 30 to 40 international unit in normal saline. Okay, slow IV infusion. By slow IV infusion we give oxytocin. So this is the first step. Give oxytocin, do massage and give tranexamic acid. If the PPH stops, if the bleeding stops, very good. But if it does not, then we need to give next drug, which is methyl ergometrin. Okay, if it still does not respond to this, then we need to go for carboprost, which is PGF2 alpha. So carboprost is said to be the best drug in preventing and treating PPH. Okay, it is the best drug, but not the first line. The first line is oxytocin. The best drug is carboprost. Now these are the 3 uterotonic agents that we can try. But even after this, if the patient does not respond, then we go for mechanical methods. What are the mechanical methods? Like massaging, which we are already doing. Next is we can insert Sengstaken Blackmore tube. Okay, or we can use the other tube, which is Packery balloon catheter. So here what we do is we fill that catheter or tube with fluid. So in Packery balloon tube we fill it with normal saline around 350 to 450 ml, and this puts the pressure on the uterus and it helps in stopping the bleeding. So this is the mechanical method. It is done after if the uterotonic agents do not work. Let's suppose that even after mechanical measures the bleeding is still going on. Then what is the next step? Then we go for surgery. Now in surgery we can either do suturing. So suturing can be either compressive sutures or other type of sutures. In compressive sutures we have B-Lynch suture. Okay, in B-Lynch suture what we do is we tie the suture in such a way that the anterior and posterior wall of uterus come in contact with each other and they are tightened. So they come in contact with each other. Okay, so this prevents the further bleeding. Okay, the other sutures are Heyman sutures, Cho square suture. So these are just the names. Okay, even after this, even after we do suturing, the bleeding does not stop, then we go for arterial ligation. We can ligate uterine artery, okay, at the level of internal os. We can ligate ovarian artery. If it still does not work, then we can ligate the internal iliac, the anterior division. Okay, right. So even after doing all this, even after ligating the arteries, the bleeding does not stop. Then it's a high time and we need to do hysterectomy. Okay, we need to remove the uterus, otherwise the patient will die. So hysterectomy, we can either do subtotal hysterectomy, which is preferred, or we can do total abdominal hysterectomy. Okay, even after this, even after we remove the uterus, still the bleeding is present. That means somewhere in the abdominal cavity there is bleeding going on. The other blood vessels are also bleeding apart from the uterine vessels or apart from in the uterus. So then we apply pelvic pressure packs. It's in the form of umbrella pack or parachute pack, and it's again a form of mechanical measure, but it is done after we do hysterectomy. Okay, so this is all the step-by-step management of atonic PPH. Now let's see about traumatic PPH. So perineal tear, we have talked about perineal tear, degrees of perineal tear, and so directly we move on to the management of perineal tear. So if it is 3rd degree or 4th degree perineal tear, okay, and if we diagnose it before 24 hours, then we immediately repair it. But if this 3rd degree or 4th degree perineal tear is diagnosed after 24 hours, then we need to wait for 2 weeks and we repair it after 2 weeks. Why? Because there are higher chances of infection after 24 hours. So we wait for 2 weeks, we give her antibiotics, or we wait for the infection to subside, and then we can repair it. So how do we repair it? If it is first degree or second degree perineal tear, then we repair the vaginal mucosa first, then the muscle, and then the skin. But if it is third degree or fourth degree, then first we repair the rectal mucosa, then the internal and external anal sphincter, and then vaginal mucosa, muscle, and skin. Okay, this is the order in which we repair. Next is hematoma. So hematoma is just a collection of blood in a cavity outside the blood vessel. Okay, so most common hematoma is vulval hematoma, and most common vessel to bleed is pudendal artery. Okay, because it is the most common artery to get damaged. So now, if the size of the hematoma is small and it is not painful, then we mostly do a conservative management. We give analgesics, and it's a sort of conservative management. Okay, but if the pain is high, there is a lot of pain, the size of hematoma is large, it's more than 5 cm, then we need to go for surgical management. And in surgical management, we drain the hematoma, we obliterate the cavity of the hematoma, and if there is ongoing bleeding, then we suture it. Okay, so this is about hematoma. Now the last cause of traumatic is rupture of uterus. Okay, so rupture of uterus, most common cause is at the site of previous C-section. Okay, if there is no C-section or there is no any scarring of the uterus, then the cause can be obstructed labor. Okay, so how do we manage this? If there is impending uterine rupture, we have talked about signs of impending uterine rupture already. Okay, so if it is impending uterine rupture, then we immediately go for C-section. Okay, and if the uterus has already been ruptured, then we need to do immediately laparotomy and repair the uterus. Right, so this is the management of traumatic PPH. So that's it. We have talked about causes of PPH. Then atonic PPH, we have talked step by step about the management of the causes, and then the management of atonic PPH. And similarly, we talked about the causes of traumatic and management of traumatic PPH. Right. So that's all for in today's podcast. We'll meet tomorrow with now I think it's the end. We'll take 2-3 more podcasts for obstetrics, and it will complete the subject. So see you in the tomorrow's podcast. Enjoy and keep studying. Bye bye.